Thank you very
So,
much, Lucy.
about your experience in using these advanced tools, or
Thank you very much, Lucy. I think this panel is very helpful for the many clinical nutritionists, also many people who are very much interested in nutrition. So I think it's very good. So actually, two panelists has already mentioned about their background. So actually, Lucy already introduced me, but I will say my background again. So I used to work as a chairman of K-Span, Korean span, in Spain. Also, I used to work in Korea. There's a Surgeons Nutrition Society. It's a surgical metabolism and nutrition. So I'm one of the founder of Korean surgical metabolism and nutrition. So I used to be president about 10 years ago. And also I have a privilege to host PENSA in 2018. At the time, Lucy, the boss of this Congress, attended also, Gilhari also was there. So it was very excellent Congress because of the support from Congress. So I want to say that I'm very much interested in the nutrition and as a surgeon, so metabolism as well. But I major in the liver and pancreas. So now, actually, I've been surgeon from 1985. So I have been surgeon more than 41 years old. So that's why I had many experience of this intestinal fistula. But about 20 years ago, I do only pancreas and the liver. As I said, I'm a president of International Minimal Invasive Liver Surgery, the LAPA liver surgery, minimal surgery president. So my major role is the liver and pancreas. So I do not have such cases like this. So, but as a surgeon, because I have been surgeon for many years, that's why I want to express my opinion on this. Actually, I heard this device from my respect friend, Professor Gilhari, and I know this is very important. Already mentioned by Professor Gilhari, already our two esteemed experts. I think this is very good because before that, the patient may experience nutritional deficiency and also the fluid deficiency. But by using this, actually, we can control the fluid and nutritional deficiency as well. But as you said, that Professor Gilhari mentioned about that the patient may have various manifestations of the malnutrition, like about the completion of the parenteral nutrition or even enteral nutrition. So patient may have some liver function derangement, like gamma GT already mentioned, also alkaline phosphatase and the liver function derangement. But using this, I think all the problem of nutritional management complication may be lessened. Also the nutritional deficiency and also fluid deficiency can be managed. And the most important thing is that this is very simple device, very simple. By using the effluent fluid to the distal limb is very simple. But I'd like to admire their very excellent idea. Actually, Professor Gilhari and his colleague has devised this method. But as I said, when I was a young surgeon, I always was afraid of this because the patient has a dehydration. Nutritional management is not easy, and there are many complications from nutritional management. But by using this, all this problem can be very well solved. Like already mentioned by two experts, the patient has stopped nutrition, and also a patient has a passed stool, and there is no need of nutrition as well, and the free nutrition. So I think this is very simple device to improve the patient care. So I admire the effort and also showing the case series to us. Thank you very much, expert.
Thank you. Using the traditional and innovative treatment and innovative system. And how about after you use this is your first time to use the innovative system, right? And how do you find it?
Yes, from the evidence that's shown in the journal articles and also from Prof. Gilhardi presentation, it is clear the benefit of Chyme reperfusion is very useful for the patient survival, recovering from his or her stomach problem. However, the difference between the traditional manual pumping compared to the inside system is the sake of practicality. It is very convenient. It's very convenient, and also it prevents spillage, because usually manual reperfusion, it is not really easy to maintain cleanliness of the area, and sometimes the enteric content can spill in contact with the skin. It causes irritation and everything. They are all solved in the new system. In the new system, it is closed system inside the bag. The pump is inside the bag, but can be driven by a magnetic motor from the outside of the stomach bag. That's the real benefit, the clear benefit, that it is now very convenient for the patient or their families to maintain reperfusion regularly, and the patient can tolerate the tube inside the bowel, so it is not painful. And like Dr. Maria presentation, usually on day 2 after the insertion, the patient can defecate normally via anus, and then it is very amazing to see the patient progression from previously dehydrated and then malnourished, and then day to day, week to week, they gain their nutrition status and no dehydration anymore. So the key benefit is that it's really convenient.
And we here have Dr. Diana Sunardi. She has experience in using this. However, maybe she has a question about using this device and also sharing. Thank you, Dr. Diana.
Thank you, Dr. Lucy. Actually, my experience was not successful, Dr. Reno and Dr. Maria. The patient was a young woman, around 35 years old. She has cancer, cervix cancer, I think. And then she said that she's feeling, she said that it's hurt when the pump started. So she doesn't want to continue. We tried to decrease the rate of the pump. It's 1, 2, and 3 stage, I think, I remember. And we decreased back into 1, but she still said that it hurts. So mine was not so simple. Do you have any comment about that?
Yeah, I think it should be related to the passage of the distal bowel. Usually, to have good result, you need to have good distal bowel. In case of cancer, it's usually there are probably infiltration of the tumor to the distal bowel, so causing maybe partial obstruction, And partial obstruction, it is painful for the patient if the bowel content is loaded with enteric content, and then the bowel peristaltic will force the enteric content to the distal, which is obstructed. So I think it is probably, in my experience, usually distal reperfusion or distal refeeding is successful if we are sure that the distal bowel is intact.
Thank you very much for the insight. Maybe I wish my next patient will be successful like
Sure,
yours.
hopefully, I mean,
Thank you, Dr. Diana. So different patients have different outcome. Dr. Maria, do you have a comment about this?
So I also tried refeeding for other patients other than the one that I presented. But for my observation, if the patient has the stoma too long, the distal one is not used for too long, usually they feel the pain. But if it's just like less than 2 weeks, usually they still can adapt to it. So I also have another patient has already the stoma for like, I don't remember, maybe about 2 years before. And then when we try to do the refeeding for her, she also complains the same thing. And we did not succeed to refeed her also.
Ability of the chyme itself, because conceptually, chyme, when it leaves the stoma, goes into a non-sterile environment. And so if the longer the chyme actually is in the stomal bag, the more chance there is in terms of microbacterial growth. So has there been any study just in terms of what is the maximum number of hours that the chyme can stay in the stomal bag before you actually need to then recycle it or reinfuse it? And also, has there been study also looking at the chyme composition in terms of degradation of nutrients, degradation of enzymes through time in the stomal bag? So to basically tell us when is the optimal time of reinfusing the chyme back into the distal bowel.
For contamination in open air, we limited 4 hours to give to the patient. Or I have experience with Dr. Maria in the very long time ago patient when we do the traditional reinfusion. We limit it for 4 hours. Then after we collect the output 4 hours, then we put in again. But it's difficult because we have to put slowly. When we put too fast, the patient will feel like a colic. Maybe Dr. Eno will have comment.
yes, we are dealing with high output fistula. The patient who is ideal for refeeding therapy is patient with high output fistula. So it doesn't take long until the stomach bag is half full. So it is recommended that we never let the stomach bag full until we repump the enteric content inside. And the beauty of the inside system that it is a closed system. We don't expose the chyme to the outside world because it's always inside the stoma bag. So, and then after the stoma is half full, we pump the chyme, but from the outside without any physical contact. It's done by magnetic pump. So risk of contamination is, I think it is much lower, although I haven't read the real scientific evidence comparing the bacterial load, but in my view, it must be a very low risk of contamination because this is a closed system. We don't open the stomach bag. The chyme is always inside the bag and never exposed to the outside world.
In your experience, how many hours do you reinfuse?
Usually not more than 2 hours, yes.
No more, because
it's
high
high
output.
output, yeah.
Yes, Prof. Gil.
Yes, I agree. If the patient meets all the indication requirements, and then they, in our experience, they very often become enthusiastic to manage the pump driver, the pump themselves. So they're constantly reinfusing, so the chyme and bile, etc., doesn't sit in the bag for any long period of time. There have been microbiological studies carried out in the British Journal Surgery paper by Ian Bissett. As a feasibility study, they did measure microbiology, and they didn't find any increase in contamination. And I'd just like to confirm that the problems usually are if the stoma has been for a long time before starting. If it's if the tube can be inserted into a fresh stoma, for example, generally it works quite well. And the last question that Theo asked, we don't know, and that's where research is required to study. The PhD student I mentioned earlier is investigating the effects on the microbiota, what micronutrient lost and replenished, but all the other enzymes and amino acids, etc., nobody, as far as we know, have measured that, and that's an area where we need a lot of more research, which hopefully we can achieve and then present at future conferences.
Yeah. And Prof. Ho-Seong-Han, because you have an experience for this, I think you must have many questions about using this innovative system compared to the traditional, or you think traditional is better?
Well, thank you very much. Yes, as a HPP surgeon, it is very not good opportunity to use this. But anyway, when I first heard about this, I think it's very excellent idea and smart ways to take care of the patient. Actually, just mentioned by Pascal Hardy, actually we are talking about the fluid deficiency and nutritional deficiency. So it is a very clear one. But still, we don't know what is beneficial in addition to this nutritional fluid. I think early mentioned by the Pascal Hardy, there's a micronutrient as well, and also there's maybe cytokine. There are another bacteria who may be microbacteria may be beneficial for the patient. So we don't know what is actually inside this chyme. So I think already mentioned we have to research further on this. But anyway, this is one new way to the very helpful method for the patient with stoma. So I think we have to further study on this and more give benefit to many patients who are suffering from the high output fistula.
Thank you. And Dr. Maria, what do you expect to? Okay, after Dr. Maria, I think this is the last question to the panelists. Dr. Maria, what do you expect about using this innovative system?
So using this innovative system, we have to educate our nursing team also, and the nurses are very excited of using this, because previously they would spend every 1 or 2 hours they have to attend to the patient for another 30 minutes, and then with this device they are having to attend the patient with less time. So they are very excited, but we need to also educate our nurses how to use it, and then I think Prof. Hardy team also helps us at first when we tried this one. And with this, we were hoping that we don't use a lot of parenteral nutrition for our patients, so cost is lower, patient is happier.
And
Oscar,
how about teaching the patient and the family member?
Oh yeah, it's very easy for the patient and on the family member to use the driver on the pump. So we just ask them to like charge it if it's already not functioning. And because we all have smartphones now, they think it's something that is cool and nice to have. And especially when I said that this is a very new device, and then also there's very few in Indonesia, they are very excited to use it.
And also, how about your patient, Prof. Reno? Did he bring home the device or?
Yes, after the insertion, and we educate the patient and her mother to maintain the pumping and how to maintain the stomach bag. They can understand it easily, and then they can practice that at home. And we keep connected with WhatsApp. We text each other if there's any problem. And so far it was good. Then the patient and her mother were very happy and maintaining the system.
Okay, that's good. And the last part, closing for Professor Gilhardi, showing the device, and also you have what is a journal, copy of journal, right?
I'm sorry?
Copy of journal that you want to,
Yes,
if anyone
if
needs that.
anyone wants a copy of the most recent publications, Sylvia has them over there on the front desk. I just wanted to show this time. This is the feeding tube that goes to the stoma. This is a little pump, and that fits into a standard stoma bag. If we had time, I could demonstrate it on myself.
Oh no, please.
And this driver that Professor
excuse
Rayner
me,
mentioned.
Prof. Hardy, because the device is quite small for the participant
Yes,
at the back. Please, if you want to see, and this is because the last session of these days. So after you see and Prof. Hardy demonstrate, then we will take picture together here. So please
Yes.
come.
Yeah, there is a smaller size tube now available, but I think the company has to understand that Asian generally
If you don't take, if you don't see now, you will see next.
My apron is not up. It's okay. Yeah. So this is my stomach.
Barbecue? Want to do barbecue?
Yeah, the tube is longer when it's available, so you cut the tube to the size to fit the patient, and then put the little pump. Sometimes need. Sometimes you need a little lubricant. Yeah.
It's a bit harder than the real
Maybe the patient has to
We
take
could
a deep
demonstrate
breath.
the pump with some artificial Chyme, but it'll probably wet my pants.
can only use the normal stomach bag. No need
With the
special.
patient easier, I think, because the patient lying on the bed,
So as Dr. Reno has said, it's a closed system, and the pump in our country anyway, generally the patients are enthusiastic to use it themselves, otherwise the nurse can go. Probably, so it's pumping it all. And as you probably know, the chyme can be different viscosities. If it's very liquid, then you have a slow speed. If it's very viscous, then you can increase the speed. And again, it depends on the diet that the patient then moves towards, and so I think we need more information and feedback on the typical diets that your patients would have. One of our first successful patients was so happy that he went out and ate a whole pineapple, which is very viscous and blocked the pump. But so we have some dietary advice that's on the company website. But that's where yourselves would be very important to develop it further. We would love to work with all you and work on the experience that Dr. Maria and Professor Reno have already achieved. Anyone
Okay.
like to?
Yeah. Any question from colleagues here? Yeah, please. One question only. Okay, two questions. Very short and answer very short.
Kapan maksimal dari operasi yang dilakukan untuk melakukan insersi alat ini? Saya punya pasien sudah beberapa tahun hidup dengan ileostomi, sudah CKD karena high output stoma yang berkali-kali, sehingga untuk malnutrisi tentu, sehingga untuk menggunakan alat ini jika memang berkenan, kira-kira apakah masih bisa?
Jadi biasanya kalau sudah lama dari sejak operasi ileostominya menuju ke pemasangan ini, itu kemungkinan usus di sana itu sudah mengecil, sudah kolaps gitu, karena jarang dipakai, malah tidak pernah dipakai gitu. Nah, untuk mereka yang seperti itu, ini bisa dicoba, tapi dengan kekuatan pompa yang ringan dulu dan sedikit dulu, lihat reaksinya. Nanti secara perlahan-lahan akhirnya usus yang distal itu terbuka lagi. Nah, jadi kekuatannya setiap hari dicoba ditambah. Indikasinya kalau terlalu banyak adalah pasien nyeri karena jadi kolik.
Seperti kasus dokter biasa tadi.
Iya. Jadi kalau yang sudah lama tuh pelan-pelan aja dulu, sedikit dulu gitu. Nanti lama-lama naik.
Yang punya dok, kan di atrofi, apakah ada ukurannya dari selangnya dimasukkan itu atau satu ukuran saja?
Satu ukuran, tapi panjangnya selang di dalam usus itu bisa digunting menyesuaikan. Jadi dia sebenarnya aslinya panjang sekali, tapi kita bisa gunting sesuai dengan ininya pasien, khususnya pasien.
Kalau nggak salah saya dapat 2 ukuran.
Oh iya.
Nomor 20 sama nomor 24.
Oh, itu untuk diameternya ya, untuk
Dan
diameternya.
ke dalam bisa disesuaikan.
Oh, bisa ditunggu nanti kalau alatnya sudah ada di Indonesia. Karena ini alat baru dipinjamkan dari New Zealand, dari perusahaan ke Dr. Maria sama program.
Ya.
Jadi memang belum dipasarkan.
Jadi nanti katanya akan ada tube untuk anak-anak.
The pediatric, you have pediatric, right? You have the pediatric device.
Pediatric tube.
Yes.
A neonatal version.
Ini mungkin last question ya, karena Prof. Gilhari will go to Bandung, and if she miss the train,
My baby is,
train.
has lost the is a device that it works on the same system for neonates. and we're the company. I'm not an engineer. The engineers are working on more pediatric system that Dr. Theo is evaluating at the moment in the UK. But again, I think it'll be very important for some of your patients. So I won't illustrate this. What was I going to say? Oh, the only negative thing at the moment, we don't have a registration of the device in Indonesia. So it's registered in most of Europe, just going to be considered by the FDA in the United States, Australia, Singapore, Malaysia. Is being used. So if any of you will go to the PENSA meeting in Bali in October, there's be some presentations from it, or Philippines as well. Apart from Dr. Maria and Professor Reno, we can supply it in most other countries for compassionate use. So if you have a patient that you think is right for primary infusion, or you have experience with manual and would like to try the device, then it possibly through the regulatory authorities we could provide it on special needs or whatever you call it. But so please do contact us. My email is available on my slides. Or
Yes,
other
I will share. Your assistant. Okay.
Thank you for your interest.
And thank you for your explanation. And this is also closing explanation. And by this, we finish with our discussion today and this session. I would like to thank to Professor Bilhadi, Professor Reno, Professor Ho Xiong Han, and the coming Professor Maria Mayasari soon. Okay, let's take picture together. Please stand here.
Okay, we will have a photo session together. Okay, yang mana dulu nih Pak? To the bigger camera first.
The bigger.
The bigger camera.
Okay.
1, 2, 3.
1, 2, 3.
Oke, semua bilang Nutri.
Okay, good. Sebentar.
Okay. Another 10 more cameras. Okay.
Okay.
Cheese.
Okay.
Okay, all done. Merapat.
Okay, 1, 2, 3. 2, 3, 4. 4, 5, 6.
Sampai 10. Okay, another camera.
Tadi ada yang ketinggalan.
Before we end this event, we would like to ask Dr. Lucy to present the certificate of appreciation to all the panelists, experts, and we've already taken a photo together.
Mas photographer, certificate of appreciation. Mantap, terima kasih.